नमस्कार एंड वेलकम टू RCI नवशिखर चैनल। RCI के नवशिखर चैनल में हमारे सभी दर्शकों का स्वागत है। आज के हमारे प्रोग्राम का टॉपिक है प्रिवेंशन ऑफ द पर्सन विद मेंटल रिटार्डेशन। एंड टू प्रेजेंट ओवर दिस टॉपिक टुडे वी हैव विद अस डॉक्टर B.S. Chavan, प्रोफेसर एंड हेड डिपार्टमेंट ऑफ साइकेट्री GMCH and Joint Director RIMH. And we have Dr. Gurjeet Kaur, Consultant in Charge, Genetics, GMCH. Welcome to RCI Navshikar channel. Progressing further, I would like to inform our viewers that they can call us for their any queries. हमारा टोल फ्री नंबर है 1800112008। हमारा स्टूडियो नंबर है 26511613 और हमारा फैक्स नंबर है 26511609। Now to begin with, I would like to say, mental retardation, it's a disability which is characterized by significant limitations in terms of intellectual functioning and adaptive behavior. And adaptive behavior in context of conceptual, social and practical adaptive skills. And it occurs prior to the age of 18 years. And we can say that according to researches, according to data and according to figures, we can say that mental retardation occurs in about 1 to 3% of the total population. Now I would like to ask sir here, जैसे कि आज हम बात करेंगे mental retardation के ऊपर, तो how common is mental retardation?
Yeah, in fact mental retardation is quite common. Let me just before we start the talk, let me just make it very clear that today topic is very relevant in the sense that whatever number of children with mental retardation we already have, we are trying our best to take care of them, create facilities for them, but more important is how do we sort of minimize the number in future,
right,
so that we are in a comfortable position.
Exactly.
So today's topic is very important for me, and I think for all the viewers who are watching us. And before I start the topic, let me just give a little bit of background, the place where we are working and the institutions we are working.
So can we have a look at the slides please?
This is the Regional Institute for Mentally Handicapped, where we have recently shifted. And this is going to be a huge independent institute working for the mentally challenged, and it will be one of its kind in the north and maybe in the country after all the services are basically added.
Okay.
And these are going to be various blocks which will come up in passage of time. So there you have the special blocks for special educations, a medical care block, you have the vocational centers, then we have an auditorium and the hostel for both boys and girls.
So we can say all in one, the parents
Yeah.
don't have to go here and there.
Yeah, and the foundation stone was laid in 2005 by the administrator of the Chandigarh, and in about 4 years time we have shifted to this block, and things are coming out quite fast. When we sort of were planning that what should we have in this institute, so we had certain objectives in mind, that this institute should cater to at least 1000 children, and that's what we are setting up the facilities. And then we had the plan in mind that there should be diagnostic and medical care for the children, there should be a vocational training center, and we wanted that we should be a nodal agency for implementation of various programs of the government. And to carry out research is a very important component.
Exactly.
We are going to add up in this institute. And the other facilities, we wanted that there be infrastructure for human resource development. So we are already starting a couple of courses so that we have adequate number of teachers to look after these persons. And it is going to be a team of psychiatrists, clinical psychologists, special educators and medical social workers who will have a very detailed assessment of the child. Because once we have a detailed assessment of the child, it will sort of put us in a position where we can plan the services.
Sir, as you said about the courses,
Yeah.
so would you please explain what kind of courses like you are planning?
Like these children, they are to be taught by special teachers.
Right.
So we call them special educators.
Right.
Right. So we are already having a 1-year diploma course for teachers like
Okay.
who are interested into the field.
Okay.
We are gradually adding up the B.Ed in special educations, and
Okay.
with passage of time, we are starting the master level courses and the PhD courses
In special education.
in special educations.
Okay.
Right.
That's very great.
Yeah. And we wanted excellent medical care facility because 60 to 70% of the children with mental retardation, they have associated physical
Conditions, yeah.
physical comorbid disorders.
Yeah.
Right. So these were certain objectives we had in mind when we were planning for these services. If you just look at the data we had of last 5 years in the clinic we are running, this is a daily clinic we run the institute.
Okay.
You will see that the number of children every year we are seeing, they are increasing, right? So they have
Right.
increased from about 918 in 2005, and last year we saw 2,345 children
That's
coming
a
to the
remarkable
clinic,
increase.
and they are not only from the institution, they are coming from the neighboring states because we
Okay.
have the excellent medical care services. And the question you asked me, so here this slide briefly shows how common is mental retardations. Generally, we take at least 1% of the total population is mentally challenged.
Okay.
The figures might vary from 1 to 3%, but 1% is the general agreed figures. Like in Chandigarh, we have a population of 10 lakhs. So in Chandigarh itself, there will be about 10,000 persons with mental retardation. That's a huge number.
Very
In the whole
huge.
of the country, you just calculate that number, it will come up to a huge number.
Right.
Right? Mental retardation is supposed to be a little more commoner in male as compared to females. Right? And the good part, this I like to emphasize, if you look at the total number of mental retardation, we see that out of the 185, that is 85% are the mild mental retardation, 10% is moderate, and the severe and profound is less common. This figure is important because when we are planning the services, we have to keep it in mind that what are the services we should have for the mild and moderate. And this is the category for 95% of the services we can teach them. They can even learn certain skills. They are in a position to take up certain employment.
Right.
So rather than planning the long-term cares, the homes, I think the emphasis should be on the training, vocational training, and then placement.
Right.
Right?
And I would like to ask here, like, most of the parents, they must have this query, like mental retardation, whether it's progressive or it's non-progressive. What's its nature?
See, whatever intelligence child has when he is born, it is not possible to increase that level of intelligence in terms of the IQ.
Right.
Right. But what can be done, whatever intelligence this child has, with training and the facilities, we can definitely improve his functioning. Right.
Right.
So that needs to be kept in mind. So IQ generally remains stable. Because what is IQ? IQ is basically mental age divided by the chronological age.
Right.
So as the child learns, his chronological age also is increasing. So this learning gets cancelled up. So ultimately the IQ generally remains stable. That's what we say.
Okay.
Yeah.
So progressing further.
Yeah. We try to look at our own data from the institute, like a different type of mental retardation. What we saw from our institution, we had about 37% of the cases who were from the mild category. Another 27 belong to the moderate, and we had 24 and 12% of the cases who belong to severe and profound mental retardation. But it is not the data from the community. The community will have a little different type of data. This data is from the institutions, the children we saw in the clinic. Right?
So what do you think, like in case of severe and profound, what is the success rate, like as you said about the training, as you said about the employment, as you said about the placement, what is the success rate, or how difficult is it to teach them and to have them make them trained and to have a placement for them as compared to mild and moderate?
Yeah, the focus of training is different according to the level of intelligence. When we talk of the profound and severe mental retardations, the focus here is primarily to teach them the self-help skills.
Right.
Right. And it is not possible to train them in terms of vocational training and the special educations. So effort is so that some of these skills they can learn and they become little independent. But it is seen that majority of the people with profound and severe mental retardations will need lifelong assistant we call it a custodial group. Custodial group would means that they are the one who need some assistance for even for their activity of daily living. So that is one group where it is not possible to sort of make them independent. They need some sort of assistance.
So the main focus is on self-help skills.
Main focus here in this group is on the self-help skill.
Like
rather than,
the daily living activities, eating,
that's
dressing,
right,
toileting and all.
That's right.
Okay.
Even in those activities, some of them would need assistance.
Right.
Right.
So these are said to be custodial groups.
Said to be custodial group.
Okay.
Yeah.
So progressing further.
Yeah. Before we talk of prevention of mental retardation, it becomes important to understand what are the causes of mental retardation. Then only we'll think of prevention.
Right.
So let me just briefly describe what are the common causes of mental retardation. We call them the risk factors which might lead to mental retardations. Broadly, we can group them into the biological causes and the environmental causes.
Okay.
The biological causes can further be divided into the genetic causes, and Dr. Gurjeet will be telling us in detail what are the various genetic causes which can lead to mental retardation. But I'll briefly be discussing about various prenatal, natal, postnatal and psychosocial factors which can lead to mental retardation.
Okay. So progressing further, I would like to ask, जैसे हम term use करते हैं mental retardation, but nowadays like the preference is intellectual disability. So what's your take on this? In your institute, you always like refer to like mental retardation, or you always use the term intellectual disability?
The most preferred and now the agreed term is definitely whatever you say is the intellectual disability. But I think it will take us time before we used to that new sort of definitions and new terminology. But definitely you are 100% right that the world over the consensus is that the mental retardations is little derogatory type of thing, and people are gradually, including the professional, are gradually trying to avoid it. But the textbooks and the communications within the ministries, right, within the department is still using the word of mental retardation, but in day-to-day people use mentally challenged also.
Right, mentally challenged.
Mentally challenged also.
So let's discuss the causes.
Yeah, if we look at the preconceptional causes would mean before the pregnancy, right? So these are some of the causes which we have seen can lead to mental retardation. Like the age is very important. The age here before 18 and after 35, they are the ages. If the girl get conceived during these ages, the chances are that there are more chances of having the abnormal growth of the fetus.
Okay.
Right. Nutrition in our country, nutritional status of the mother is still very, very important. I'll be discussing the data we had from the institute, where anemia is one of the leading cause of mental retardation in our setting.
And plus, like if talking about like nutritional status, I have read somewhere like folic acid tablets and iodine salts are also important during the pregnancy.
Yeah, when we call of nutritional status, that includes your vitamins, includes your carbohydrates, right? All those things.
Right.
Even like folic acid, you rightly said, is a very, very important component of the diet of a pregnant lady, right? The mother who's having deficiency in terms of the folic acid can lead to various neurotubal defect. Even Dr. Gurjeet will be taking up that. The deficiency can lead to that. Maternal stress is another important factor. Like during even before the child, the girl is planning, the stress at the back of mind is a very important determinant. The mood, depression, anxiety, lack of sleep, those are the important things.
But like if talking about maternal age and nutritional status, that are I think they are supported by researchers and all with the facts. But what about like maternal stress? Do we have a like handhold ya like the strong reason behind it, like maternal stress cause mental retardation? It's just a like seeing in the cases a wild guess is just like a maternal stress cause mental retardation.
No, now I think there's data to support that. There was a time when it was just an assumption that the stress can lead to the effect on the fetus, but I think now there are double-blind controlled studies where the people have specifically looked on two groups, where the mother had a severe stress during the pregnancy and before pregnancy, and the other lady who did not have stress. So definitely now the data is supporting that yes, the stress during pregnancy, even before pregnancy, is important.
And do you have like cases in your like RIMH and GMCH where the like maternal stress played a very important role?
Yeah, I think during my presentation I might take up, and we might have the data
Okay.
to sort of discuss that also.
Okay.
Here the other point, the addictions among the girls and mothers is important. May not be a major issue in our setting, but definitely in the West, the alcoholism is a major
Right.
major problems. Low socioeconomic status and large family structure, indirectly the poverty, is also important factor which might be responsible for the mental retardation in the fetus.
So how come poverty? Would you like to explain that?
Poverty indirectly because the poor antenatal checkup. A lot of these mothers, they don't go for the checkup. They might have associated medical disturbances which were never diagnosed. They may not go for immunizations. They may not take a balanced diet, right?
Okay.
So indirectly poverty is playing a role.
Right.
If we look at the prenatal factors would means during the pregnancy, right? There's a huge list of factors which might be operating and indirectly affecting the fetus. We have seen that mothers who have gone repeated abortions in the past before they have finally decided to go for the continuation of pregnancy are at risk. Poor nutrition we have just discussed, diabetes during pregnancy, RH incompatibility where husband is RH negative or positive, and there is incompatibility between the two. Then the hypertensions, increased blood pressure during pregnancy, convulsions in mother, infections, physical trauma during pregnancy, drugs, emotional stress. There's a huge list of factors. This has been seen that a lot of these factors might be operating in combination rather than independently.
And the like infections you said, what kind of infections like it can happen in prenatal stage?
Like the viral infections, like influenza, encephalitis, where the viral infection can go to the brain, right? Even UTI, urinary tract infections. A lot of these infections, like syphilis, could be another. Gonorrhea could be another. A lot of these infections during pregnancy can affect the child. The
And like
fetus.
rubella, which
Rubella,
like
yeah,
which
yeah,
affect in the first
definitely,
3 times
definitely
of
rubella.
pregnancy.
Yeah, you're right. So all these infections can affect the fetus.
And like prenatal factors, if we are talking about at the time of pregnancy, so can we say exposure to X-rays and like unprescribed medications, if taken, that can also lead to the mental retardation?
Right, right. Because there was a huge list of things I could not include, but you're right that all those factors are equally relevant. Excessive exposure, definitely, and unscheduled, unprescribed, excessive drugs, which might, particularly during the first trimester of pregnancy, the first 3 months of pregnancy, are very important.
At this point, I remember a case. Like we also had clinics in our college, and we attended the case. There was a mother coming up, and she just skipped rope like to have an abortion, and that was not successful. And she took some homeopathy medicines, but that was not successful. And she came to know after 3rd and 4th month that yes, the fetus is still there, and that resulted into the mental retardation.
You're right.
So
You're
skipping up ropes and taking homeopathic medicines and unprescribed medications is also very harmful, and that can also lead to the mental retardation.
right. Right, right.
Then progressing further.
When I was talking repeated abortion, I think some of these were attempted abortions which were not successful and the child was continued.
Right.
Might be the like same thing might have happened you had just discussed.
And plus there is also an important factor which is said like spacing the pregnancies.
Yeah.
Like after one child, like there has to be a gap.
Yeah, because you have to have time to look after the child, and once it becomes independent, then you should plan for the next pregnancy,
Right.
rather than lining up and then taking up the huge stress. And then if you look at the natal causes, they are more important, more common in our culture, in our settings. Like we see that delivery which were premature, child was born before term, even sometime post maturity, multiple pregnancies, prolonged labor, then use of forceps during delivery, excessive bleeding, prolapsed cord, convulsions, unhygienic delivery, which means there was some infection during delivery, large head. So we have seen that all these factors are operating and can lead to the effect on the child.
So as you described about large head, would you like to explain that?
Because large head would mean that it will be a prolonged labor, because we are attempting that let it be vaginal delivery, But if the head is lost, there is no progress. We are waiting, and it is seen that there is a lack of oxygen in case the delivery is prolonged, right? So you have waited for hours together, then you have suddenly planned the emergency cesarean sections.
Right.
So there was no time for preparations. So a lot of things are happening together, leading to delayed in everything.
And what is the most attributable cause, like in the natal period, which can be like linked to the mental retardation? Like, is it birth asphyxia or some? What is the most attributable cause?
The most common will come, the data we are sporting from our institution is basically the delayed cry, the lack of oxygen immediately after birth.
Okay.
Whether the child has have taken anything, has something has gone into respiratory tract, or there was a cord around the neck, so child was not able to breathe. So there was a delay in oxygen to the brain. So the delayed cry and the problems in respirations are very, very important cause.
Okay. Then moving further.
Yeah. These are the postnatal, immediately after the birth. The delayed birth cry I was just mentioning as an important cause. Low birth weight, neonatal sepsis, the infection of the neonate, respiratory distress I just described, the trauma to the child, the newborn, the seizure. Some of the children, because of the associated medical problems, have the seizures. Then there is an increase in bilirubin, which can affect the brain. There are toxin, there are lead poisoning. Some of these factors are important immediately after the birth.
Like as you said about neonatal hyperbilirubinemia, that means jaundice?
I mean jaundice.
Okay.
Because generally in the fetus there is an increase in bilirubin. Sometimes we call it a physiological jaundice. That means with passage of time, within 3 to 4 days, the levels of bilirubin comes down. But in case there is RH incompatibility, the levels of bilirubin, they go up to the level of 15, 16, 18. That is the level when they start affecting the brain, and we have to immediately admit the child and go for the phototherapy. But if this delivery takes place in the remote area where we do not have a facility for diagnosis, even for treatment, then it's affect the child.
But nowadays, sir, like every newborn child is having jaundice. So what's your take on this? Proper screening is necessary, like in case of that, because every newborn child nowadays is getting jaundice.
We can't say all the newborns children are
Majority
getting jaundice,
of them,
but yeah, it's common. But immediately after birth and on the third or fourth day, the detailed examinations by the child specialist, who can clinically look at the child. If there is a doubt, he can go for the investigations, because the blood test for the bilirubin is very simple, right? It's not very cheap also.
Right.
So definitely by the levels of bilirubin, we can immediately find out where there is a need of any further interventions.
And what about diarrhea? Can it also lead to mental retardation, like at the postnatal stage of the child?
Yeah, in our setting, infections, dysentery leading to dehydrations, and diarrhea leading to dehydration is quite common in our setting. Because once there is a dehydration because of diarrhea, that means the supply of blood to the brain because of dehydration will reduce. If there is less supply of the blood to the brain, there is less oxygen to the brain, and that can lead to the damage of the brain.
And like you said about lead poisoning, and recently we heard like some toys, they contain lead, so that may harm.
That is common, and it's much more common in the labor class, where the newborns are left around the roadsides.
Right.
They eat a lot of mud, and this mud might have the excess of lead. So lead poisoning, sometimes we are not putting our lot of emphasis on it, but this is quite common.
So we have discussed about the causes of the mental retardation and the prevalence and the incidence of the mental retardation. We'll surely carry on with our discussion after a short break. See you after a while.
The chief handicap of the blindness is not blindness, but the attitude of seeing people towards them. आइए जानने और समझने की कोशिश करते हैं कि बधिरांधता यानी डेफ ब्लाइंडनेस क्या है। बधिरांधता एक स्थिति है जिसमें दृष्टिहीनता एवं सुनने की शक्ति में कमी आती है तथा जिससे विचारों के आदान प्रदान और रोजमर्रा की आवश्यकताओं की पूर्ति में समस्या उत्पन्न होती है। बलराम एक 9 साल का बधिरांत बच्चा है। वो एक प्रीमैच्योर बच्चा है जिसका शारीरिक विकास उसकी आयु के अनुरूप नहीं हुआ था। वो एक निम्न वर्गीय श्रेणी से संबंध रखता है तथा 5 साल से लगातार नेशनल एसोसिएशन फॉर ब्लाइंड दिल्ली के प्रशिक्षण कार्यक्रम से संलग्न है। इन 5 सालों के अंतर्गत उसे रोजमर्रा के कामों में, हलन चलन में, उसकी शैक्षणिक जरूरतों के अनुसार संप्रेषण द्वारा प्रशिक्षण दिया गया है जिससे वो इन सब क्रियाओं में स्वावलंबी बन सके। बलराम बिना किसी सहायता के चाकू से फलों को काट सकता है। उनके छिलकों को कूड़ेदान में डाल सकता है। अपने बर्तनों को खुद साफ कर सकता है। उन्हें सही जगह पर रख सकता है। सही बर्तनों का चयन करके खुद खाना खाता है। एवं पानी की बोतल निकालकर पानी भी पीता है। इन सभी क्रियाओं में वो टेक्चुअल साइन लैंग्वेज से निर्देशों को ग्रहण करता है और अपने भावों को व्यक्त करता है। टेलर फ्रेम और ब्रेलर द्वारा गणित, पठन लेखन में भी प्रशिक्षण प्राप्त कर रहा है। सभी बच्चों की तरह उसका भी एक मनपसंद खेल है। उसे सेल फोन को अपने कानों पर लगाकर उसका कंपन महसूस करना अच्छा लगता है। कहा जाता है, वॉकिंग विद अ फ्रेंड इन डार्क इज बेटर देन वॉकिंग अलोन इन लाइट। कहने का तात्पर्य है कि वो लॉन्ग केन ट्रेवल, टैक्टाइल पाथ, ट्रेलिंग और लैंडमार्क्स द्वारा हलन चलन में भी सक्षम है और व्यायाम संबंधी क्रियाएं जैसे ट्रेडमिल, स्टैटिक साइकिल का स्वचालन भी कर सकता है। कहा गया है, द बेस्ट एंड मोस्ट ब्यूटीफुल थिंग्स इन द वर्ल्ड कैन नॉट बी सीन और इवन टच्ड, दे मस्ट बी फेल्ट विद द हार्ट।
वेलकम बैक। ब्रेक पे जाने से पहले we discussed about how common is mental retardation. Sir told us that mental retardation occurs in about 1% of the total population, and it is more common in males as compared to females. We have seen that mild and moderate mental retardation, they are of more occurrence as compared to the severe and profound mental retardation. As for example, the mild mental retardation accounts for about 85% of the cases, and moderate mental retardation accounts for about 10% of the total cases. And in case of mild and moderate mental retardation, the focus is on their training, on their special education, on their further vocational training and placement. But in case of severe and profound mental retardation, we have to focus on the self-help skills, which are daily living activities such as eating, drinking, dressing, toileting. Then we discussed about the different causes of mental retardation. The causes of mental retardation can be divided into two groups, which are biological and environmental. The biological can again be divided into two subtypes, which are genetic, and the second one can be divided into the prenatal, natal and the postnatal causes. We have discussed about certain prenatal, natal and postnatal causes. Now sir, what we are going to discuss next, like we have discussed the causes in prenatal, natal and postnatal stages.
Yeah.
What we are going to discuss next?
See, whatever I have shared informations regarding the causes, basically that was from the literature. And when we go through the literature, that's most of the textbooks are from the West. And when we try to apply that data to our own setting, we do find the differences. So let me just briefly share that whatever causes we have discussed can lead to mental retardations, how common these are in our setting. So we have the data from the institute, and I'll be briefly sharing in next few slides whatever information we have regarding the causes. Like in this slide, we have shown that in our setting about 22% causes of mental retardations were because of the genetic disorders. And here we have Dr. Gurjeet, who will be telling us in detail about the genetic disorder. Isn't Dr. Gurjeet? You will be
Yeah, genetic disorders play a very important role in mental retardation. So we are going to next, like within few minutes, we will discuss about how genetics play a very important role in mental retardation.
And as ma'am, we are discussing about causes of mental retardation, it is that doctors find the specific causes in only 25% of the cases. Rest of the cases of mental retardation, they are not very sure like what particular causes like there behind the mental retardation. What's your take on this?
Yeah, because in case of mental retardation, there are not only like one particular thing which is involved, like we can say just chromosome, it is the genetic, it is the environmental, and lot of things are together to have a mental retardation. So when we will take about genetics, then it will be very clear like how mental retardation is developed during the development of a child.
And as sir discussed about the like drug abuse and like certain alcoholism, sir discussed about that cause also. So it's the kind of like fetal alcohol syndrome which can be developed because of that, which can also lead to mental retardation.
yeah, but we don't see that quite often in our setting, because
More in Western
Yeah,
countries.
yes,
More in the
because
West.
alcohol is not so common in Indian population.
But yes, in the tribal population in some of the states of India, where like Madhya Pradesh, if you go into the tribes, then ladies do take a lot of alcohol. So there are reports that yes, it leads to the alcohol fetal distress syndrome.
Which can ultimately lead to mental
Yeah,
retardation.
that's right. So other than the genetic causes, let me go ahead and share the information about the other causes. Like if we leave aside the 21%, if we see the preconceptional, the point I was trying to make during my presentation in the beginning, I was saying that the poverty, that is the below poverty line families and the large families, they 84% of the children in my institutions came from these families, and another 42% has the large families. There are more than 5, 6 or 7 family members living together in a small hut, in a small house. So it was a lot of crowding. So that is where we say that poverty and the mental retardations, they are related closely.
Right.
Right. That's a very important and a very significant findings we have from our study. This is the same, like this is basically the preconceptional. I was trying to look at the whether the age is important in our setting, but somehow we didn't see that we have that just 10% were less than 20, and if we saw the more than 30 years of age, it was less than about 5 or 6%, and majority were within the 20 to 30 years of age during pregnancy. That's the right age. But again, this is the same BPL families and the large families which were important for us. this is the data we were discussing. So if you look at the data from our institute, we see that 32% of the females they had undergone abortions, whether it was complete abortions or it was an attempted abortions, and less number of cases had the bleeding and the maternal infections and the anemia in our setting. But this was a very important finding. The same chart. If you look at the natal causes, again this is a very important finding from our institute. Like 28% of the children who reported to the clinic, the mother had either the prolonged labor or it was a difficult labor, and 32% were the home deliveries. So here indirectly it indicates that yes, possibly during the delivery either the child suffered some trauma, or there was a delayed cry which was not managed because the oxygen was not available. So the message is that yes, these causes here 50% are the preventable causes of mental
Right.
retardations. So that is a very important message for the viewers who are seeing this program. So can we have the program in place where at least the preventable causes of mental retardation are looked at and the programs are accordingly planned?
I would like to ask you,
Like
ma'am.
in genetic disorders, we cannot.
Yeah.
But these are preventable causes, so we should at least try to prevent this, so that we can reduce the number of mental retardation.
But like as we are seeing, like home deliveries, that accounts to about 32%. So like in rural population where most of the deliveries are conducted at home and with the help of Anganwadis and midwiferys. So what do you think, like Anganwadi, it's a like best possible way to have the delivery at the midwifery? What do you say on this? Because there are no
See-
like only primary health centers in like far off villages, and only Anganwadis and midwiferys are available there. And like it's also been said, like the instrument which they use to cut the umbilical cord, that's also infectious, which can lead to the infections into the newborn child.
Yeah, see, we can't do anything because in rural population we are not having good hospitals, and these services are not there, and that's why the mental retardation rate is high. But we can only do is we should try to have good facilities in the rural areas, so that we can at least whatever cause we can prevent, we can prevent that mental retardation.
We
there.
can train the
yeah.
the Anganwadi or the
Yeah,
midwiferys.
in fact, that was the reason when the government of India came up with the trained dai, the concept of trained dai.
Okay.
Yeah.
Because what they did, they said it was not possible to sort of prevent the home deliveries. So what they did, they picked up the ladies who were called dais in the village, so they gave them a short training. But what is required? See, they were given short training, but there's a need of this refresher training.
Right.
Things are changing.
Awareness
Exactly.
is
Yeah.
very important.
So let
like,
this certification for a trained IV for a limited period of time, and let her undergo some additional training in case she wants to practice this, so that she is made aware some of the things which are changing. She is told about that.
Yeah, to keep them up to date.
Yeah.
Keep them up to date.
And as I discussed about BPL families below poverty line, and the main possible reason which we can attribute here is the malnourishment
Yeah,
which
that-
they go through. So don't you think government should like plan like this some supplementary nutrition scheme also in the rural area, like
that
to
will be
prevent?
best. Like that should be our ideal thing to take place, so that the if here what is the problem happening is the government is not involved too much in taking care of this disability. If government plays a important role, then we can prevent
Exactly.
lot of this disability.
Like we have a midday meal scheme, but
Exactly.
that is for the children going to school.
Right.
Why can't we have some scheme for the pregnant ladies from
Exactly,
the BPL,
yeah.
BPL families? Because that's the time when more nutrition is more important rather than when the child is born.
In the integrated child development scheme, I think pregnant ladies are also involved, like the lactating mothers and the pregnant ladies, but that didn't add up to any result.
See,
Like,
now government is giving, after if a girl child is born, they are giving some money. They
Exactly.
should give money for this nourishment, their food, and so that whole 9 months they are able to have a good nutrition.
Exactly, and as you said, like 50% of the causes, these are preventable.
Yeah.
So government should take major steps like for the major accountable causes for the mental retardation.
Yeah.
So progressing further.
Yeah. Same thing in the bar chart. And the postnatal causes, again a very important sort of finding we have from here. Like 41% newborns had the low birth weight at the time of delivery. That means there was a problem during pregnancy. Either there was a malnutrition or the mother didn't look after very well, and 47% of the children had delayed cry. Look at the finding we have. That means these 47%, in these 47%, the cause of mental retardation was the lack of oxygen, timely lack of oxygen. Again, very preventable causes of mental retardations.
Right.
Oxygen, and there are also certain inborn error of metabolism which are genetic. Like if they are treated timely, we will talk about
She'll
that.
come to that.
Because
genetic causes.
most of this mental retardation can be prevented because inborn error of metabolism is playing a very important role, and timely management. There are like those disorders can be managed timely, and we can prevent mental retardation. And they are like hypothyroidism, and these are very common
She'll
causes.
come to that.
We will
She'll
talk
come to
this
that.
one.
About the genetic
Yeah,
factors.
That's
factor.
right. That's right. These were some of the congenital causes. I think again Dr. Gurjeet will take up. Let me just briefly say, like you ask a question, or you might ask a question, what is prevention of mental retardations? So the prevention of mental retardation, the aim of preventive medicine is to reduce perinatal as well as neonatal mortality, and to ensure complete freedom from physical and mental handicap later in life. So that is the whole aim of the preventive medicines, and these are the three levels of preventions. We can have the primary prevention, where we can talk of the genetic counseling, we can talk of the prenatal screening, we can talk of maternal health checkup, immunization program, balanced diet. Then there is a secondary prevention, which means that there is a dietary program for children with metabolic disorders. There is early intervention clinic. If that doesn't happen, we are delayed, then we can talk of the tertiary prevention. That is the rehabilitation services, surgical interventions, assistive devices. So we'll be talking of these three levels of prevention.
Means like in terms of primary prevention, we can say these are certain set of investigation things like to reduce the risk, to eliminate the risk of having mental retardation.
That's right.
And in terms of secondary prevention, we can say halting the disease progression further.
Yeah, so that there's no further damage or deteriorations. So we are intervening and stopping the further damage. Yeah,
damage.
Yeah, that's
And
right.
in terms of tertiary prevention, we can say like preventing the further complications and maximizing the function so that they...
Yeah, more of the providing assistance to the person who is already having problems, so that he can live a comfortable life. So he has a handicap. So either we provide him some support, like in terms of assistive devices, so that we can't do anything about the handicap, but let's do something where the distress because of the handicap is minimized.
Right. And as you said about like early intervention. So how far early intervention is important? How far it is helpful in terms of mental retardation?
Very
important.
very important.
Very important.
Very important.
For certain disease, for certain we need like early intervention it can completely prevent mental retardation.
And what do you say, like the early intervention at what age of life, at what period of life, like up to
Within 24 hours, within 24 to 72 hours.
And like in terms of like you said about your special education units and all, like in terms of that we can say the critical period is up till 5 years of age, and within that period the brain is best growing, so we can have the possible stimulation and training to prevent the, as we said, the secondary prevention, to prevent the further damage and halting the disease progression. So early intervention is
Early
very
intervention
necessary.
and treatment, like we have to have a diagnosis, and then that child has to be managed through treatment. So treatment is also important. It should be available there so that the child can avail that treatment continuously, timely, so that then we can prevent mental retardation.
The youngest child we had in our early intervention clinic was 4 months old.
Oh,
So
that's
at 4 months, the parents had some doubt that yes, during the delivery, immediately after the delivery, we found that the child has or likely to have problems, so they landed up in the early intervention clinic. So that's the age we are trying to target. Let
Exactly.
the parents know yes, there's something wrong, and they should know where to go, and they should follow the instructions.
And I think early intervention period, they can be best justified and identified by the parents at home, whether the child is having problem or not. Like
See, they
instead
can
of
have
having
delivery at home, it's okay, but they now the system, it is very easy. They can send, if they are aware about all this, they can send the sample for analysis within 24 to 72 hours, and they can get their test done of their own child, and at least can prevent those disorders which can be treatable, at least those disorders which we can pick up here in India itself. There are a lot of disorders which we can pick up, but in India, okay, we say we are from the developed countries, we are behind them, but at least those which we can at least pick up, we should go for those testing.
Okay, ma'am. So progressing further, I would like to ask, what are the common genetic disorders which lead to mental retardation?
See, we can divide the genetic disorders into two major groups, like chromosomal disorders and gene disorders. The commonly existing chromosomal disorders are Down syndrome, Edwards syndrome, Turner syndrome, Klinefelter syndrome, and the gene disorders are like galactosemia, phenylketonuria, Fragile X, Wilson disease, and many. So
Yeah. For a common man, as we are discussing about the genetics and the chromosomal disorders and gene disorders, for a common man, what you can say, what is a gene and a chromosome? And how do they contribute to the transmission?
Human body is made up of cells. We are all made up of cells, and this cell consists of like a nucleus in it, which is containing the chromatin material.
Okay.
This chromatin material, what is this chromatin material? It is nothing but it is 23 pairs of chromosome.
Okay.
These chromosome contain biological unit of hereditary, which we call as gene. And these chromosomes, we are saying 23 pair. These chromosomes are arranged in this order, like they are paired 1, 2, 3, they are numbered. These now till 22 we call them as autosome, and the other 123rd is called sex chromosome. In male it is XY and in female it is XX. So this is a normal, this type of arrangement of chromosomes is called karyogram. This is a normal karyogram. But if we see now here, we see they are all these numbers, chromosome are 2 in number, but if we see the number 21, it is 3. This is this type of inheritance of chromosome is called like it is different than normal, so it become a disease state. So this is like this type of inheritance of chromosome 21 is called Down syndrome, and which is also called trisomy 21. Trisomy 21 means that there are 321 chromosomes, and this is like around 1 in 800 and a major cause of mental disability. And like here, this is another syndrome, another disease state when the chromosome number 18 now here is 3 in number, and this is also 1 in 6,000, and it is also a leading cause of physical and both mental handicap. So, and like here in Turner syndrome, this is also one of the type of syndrome where there is one X chromosome, the number is 45X. This is like in female it is only one X and the other X is not there. So such type of inheritance of the chromosome from the parents to the child can lead to mental retardation. And also sometimes this is example of Klinefelter syndrome when it is 47XXY. Now here there are 2 X and 1 Y. So it is having the characters of both breast development is there, and then it is the small testicular size is there. So it is having both X and Y characters. So such type of disorders come under chromosomal disorder, and those were like trisomies, like one more extra chromosome is there. But sometimes what happen, there are structural abnormalities. Structural abnormalities mean that one part of this chromosome has gone and binded here.
Okay.
And this is very common, like we were talking about spontaneous abortion. So this type of arrangement is very common. When such type of arrangement take place, there are spontaneous abortions are taking place, one after the another. The spontaneous abortion take place. So these can be either deletion. Such type of structure can be deletion, duplication, that is the chromosome can duplicate, or there can be inversion, it can be translocation and insertion. All these are the leading cause of chromosomal disorders. That is, the number of chromosome can change, or the structure of chromosome can change, or there is alteration in the gene structure. All these can lead to both physical and mental handicap. Now, what is gene structure? We have talked about the chromosome, and the genes, we know they are present on the chromosome.
Now, she's coming to your question. You said for a common man,
Right.
what is a gene? I think this slide is going to be important to understand for a common man what is a gene.
Right.
See, what
Like,
is
and you told about the karyotypes and all. This will be more easier in a way for a common man to
Yeah,
understand.
this is very easy. Like,
Yeah.
our chromosome, they are what? They are just DNA, and they are made up of these bases like adenine, cytosine, thymine, guanine are the basic unit for the making up of DNA. Now, these can be any arrangement. The sequence in a gene can be any arrangement of these base pair. Suppose this is the sequence. Now, for a layman to know what is this, we take this sequence as the fat cat ate the rat. Right? Now, this is the sequence. We say AACTAC. What does it represent? It represent a fat cat ate the rat. Now, this if suppose one here this sequence is removed and insert something, suppose instead of A the C is coming. It can be anything. It can be G, it can be A, it can be T, whatever can one just change in this sequence. Now see, if suppose A has changed and C has come, the whole sequence changes from the fat hat ate the rat.
Right.
And now this is the sequence which is coding a normal protein. Protein are required for the all metabolism,
Right.
structure. The proteins are required for the both growth and development of human body.
They are the
Now,
building blocks of
building
life,
block,
yeah.
yeah. So if there is change in this sequence, just one base pair is removed. It can be 2 are removed, 3 are removed, or just one single. We are just talking about single change in the base pair, and whole sequence is changed. From the fat cat ate the rat, the sequence has now become the fat hat ate the rat. That is, the normal protein has changed,
Right.
and some other protein is synthesized which can't perform the normal function. So if we take an example, sickle cell anemia. If we talk about sickle cell anemia, what is sickle cell anemia? Just a T has been changed by A, and the whole RBC, normal RBC, change into sickle cell, and it becomes a disease state. So this is gene mutation. These are called gene changes.
Okay.
So both of them can lead to either physical disability or mental retardation.
And as you discussed about the Down syndrome and the Edwards syndrome, in Down syndrome, that's the most attributable cause for the mental retardation. What is, like sir told about mild and moderate and severe and profound cases? What kind of case we get to see in Down syndrome of the mental retardation, either of the mild category or of the moderate or of the severe or of the profound?
It is in Down syndrome, if all the cells are trisomy 40 from
21.
46 to they are like 47, that is the 21 number is one increase. For our human body, the normal human body is made up of 23 pair, and now it becomes 23 plus 1. So if the cells have changed, the number is changed, the protein synthesis will change, all the whole mechanism of body will be changed, and that is going to lead to, now it is the disability will be there. Now the environmental factor play important role. In which environment, how the child is going to be developed.
The point Kirti had, generally what type of disability or a mental retardation we see.
Which category of
Generally we see a milder type of
mental
mental
retardation?
retardation. Mild to moderate is the most common type of the mental retardation we generally see with children with the Down syndrome.
Okay.
right, as compared to the profound and the severe form.
They can go to school, they can understand, they can eat on their own, they can talk. So it is
They're trainable.
trainable, and environmental factor help them to develop. And if it is mosaicism, like mosaicism is also one type of
Down syndrome.
inheritance
Okay.
pattern. Like all cells are not 47, few cells are 47, and few cells are 46. So it depends. Now there is two types of cell, 46 and 47 together. So if such type of pattern exists, then it is they can grow. They will have low IQ, but they will develop as a normal man with a low IQ.
So up till now we have discussed about the biological causes for the mental retardation, which can be attributed to the genetic and the prenatal, natal and postnatal causes. We'll carry on with our discussion with the genetic causes after a short break. See you after a while.
This is Aparna. She loves chess and Shah Rukh Khan. Her best friend is Swati. She also has visual impairment. This is Neeraj. He plays many instruments. He loves Mohammad Rafi and cricket. He also uses crutches for mobility.
चंदा है तू मेरा सूरज है तू
This is Raj Bala.
मेरी आँखों का तारा है तू जीती हूँ मैं बस तुझे देख कर
With her husband and daughter. She loves cooking and watching TV.
सूरज है तू आ मेरी आँखों का तारा है तू
She also has cerebral palsy. Look beyond the disability. Look at the person.
हम होंगे कामयाब, हम होंगे कामयाब, हम होंगे कामयाब एक दिन। ओ मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन। We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe that we shall overcome someday. We shall overcome someday. We shall overcome someday.
The state of knowledge exists. The will, the capacity, and method are usually the problem. मानसिक मंदता एक ऐसी विकलांगता है जो 18 वर्ष की आयु से पूर्व कभी भी हो सकती है, जिसमें व्यवहार अनुकूलता में कमी एवं बुद्धि क्षमता 70% से कम होती है। Alone we can do so little. Together we can do so much. भारतीय पुनर्वास परिषद द्वारा देश भर में पंजीकृत केंद्र इस बात को प्रमाणित करते हैं। NIMH प्रादेशिक केंद्र नई दिल्ली एक ऐसा ही केंद्र है जहां छात्रों को प्रशिक्षण दिया जाता है। जिसके उपरांत वे मंदबुद्धि बच्चों की सेवा में नियुक्त होते हैं। क्लासरूम टीचिंग, ग्रुप टीचिंग एवं भारतीय पुनर्वास परिषद के नव शिखर चैनल पर प्रसारित टेलीकॉन्फ्रेंसेस द्वारा संबंधित विषयों पर विस्तार पूर्वक ज्ञान दिया जाता है। मेडिकल, ऑक्यूपेशनल थेरेपी, फिजियोथेरेपी, स्पीच थेरेपी, साइकोलॉजी और स्पेशल एजुकेशन जैसे क्षेत्रों में छात्रों को प्रशिक्षित किया जाता है। प्रयोगात्मक अनुभव एवं अभ्यास के लिए टीचर ट्रेनिंग प्रोग्राम के उपरांत छात्रों को मंदबुद्धि बच्चों के साथ कक्षाओं में नियुक्त किया जाता है और इंडिविजुअलाइज्ड एजुकेशन प्लान का भी आधार बनाया जाता है, जिससे वे संपूर्ण शिक्षा एवं चिकित्सा शैली को समझ सकें। इस पूरे प्रशिक्षण कार्यक्रम के दौरान विद्यार्थी जर्नल्स, न्यूज़लेटर्स, पेरियोडिकल्स, चार्ट्स, मॉडल्स, कंप्यूटर ट्रेनिंग एवं टेक्स्ट बुक्स का उपयोग कर सकते हैं। कहते हैं, कीप योर फेस टू द सनशाइन एंड यू कैन नॉट सी द शैडो। इसी बात को ध्यान में रखते हुए विद्यार्थियों को सरकारी एवं गैर सरकारी संस्थाओं में नियुक्त किया जाता है, जहां वे मंदबुद्धि बच्चों के लिए निरीक्षण, प्रशिक्षण एवं अनुसंधान का दायित्व संभालते हैं और इसके पश्चात ये विद्यार्थी इस प्रशिक्षण का उपयोग मंदबुद्धि बच्चों के सामाजिक एवं शैक्षणिक उत्थान एवं विकास में करते हैं और एक लक्ष्य की ओर आगे बढ़ते हैं। और फिर लक्ष्य कितना ही दूर हो, फासला नजरों का धोखा भी तो हो सकता है। वो मिले या ना मिले, हाथ बढ़ाकर देखो।
Welcome back. If we say about the prenatal, natal and postnatal causes, then we can say the most common cause of mental retardation in the prenatal stage is abortion. In the natal stage, the most common cause is prolonged labor, and in postnatal, it's delayed birth cry. Coming to genetic disorders. Why genetic disorders arise? It's because of change in the number of chromosomes or the structure of chromosomes or the alteration in the gene structure. And genetic causes accounts for about 21% causes for the mental retardation. Up till now, we have discussed about Down syndrome, which is trisomy of 21st chromosome, and it occurs in about 1 in 800 births, and it is the most common cause of mental retardation. If we talk about Edwards syndrome, then we can say there is a trisomy of 18th chromosome, and it occurs in 1 in 6,000 live births. Then we discussed about the Turner syndrome, which is 45X condition, and if we discuss about the Klinefelter syndrome, then it's 47XXY. Now I'm coming to genetic disorders. We have discussed about various genetic disorders like Down syndrome, Edwards syndrome, Klinefelter and Turner syndrome. What are the steps, or how we can prevent these genetic disorders?
Yes, we can prevent genetic disorder through various ways. That is, one is prenatal screening program, through newborn screening program, and finally through genetic counseling. So what is prenatal?
Screening, yeah.
Prenatal screening is that prenatal screening includes detection of certain genetic disorder in the fetus before birth. That is, with the advancement in medical science, it is now possible to detect large number of genetic and metabolic disorders before a baby is born, that is in the fetus. What happens that through prenatal screening there are certain genetic disorders like chromosomal. Now we know what are chromosomal
Right.
disorder. Same way there are neural tube defect, gene disorders we know, and inborn error of metabolism. They can be prevented before birth, that is in the fetus. Like how we can prevent them is like we can, what happens during pregnancy, there are certain biochemical markers which are produced by the fetus, and it travels to the mother's bloodstream and can be measured during the development of fetus during the prenatal time, and this is called prenatal screening. And this is these biomarkers can detect certain chromosomal disorders or neural tube defect. These biomarkers are alpha fetoprotein, pregnancy associated plasma protein, free HCG beta, unconjugated estriol, and inhibin. And these markers can be tested twice during pregnancy.
Like we do blood test and we do stool test and all. For these tests, like to identify the biomarkers, what kind of test we go through? Like what is the sample which we take?
We
generally?
take blood.
Okay.
What we do is these biomarkers are produced by fetus and they travel into mother's bloodstream through the placenta.
Okay.
And from the mother's blood we detect this biomarker for the fetus, and that's why we call it as a screening test, because screening is going to not give a confirmatory result. It will group the fetus into a low risk group or a high risk group. So because as we are screening the fetus from the mother's blood.
And like sir, as
But
ma'am
see,
mentioned
like
about
Dr. Gurjeet has certain clips, like she can document, she can show us what do we do for screening of these tests.
Okay,
Dr.
that
Gurjeet,
would be
would
very
you-
good.
Yeah, if we can just have a look at the clips you have for the
Yeah, and as ma'am discussed about the neural tube defects, like they can be like spina bifida and
Spina bifida, then in which there is a deformity in the
Now the video has been started. Can we have a look at the video, please? Ma'am,
yeah,
so here this is like we are giving a group counseling to the pregnant ladies which come to genetic center. We tell them about how this what are these chromosomal disorder, neural tube defect, how they are inherited. Like we are talking here about trisomy 21, trisomy 18. We tell them about Down syndrome, Edward syndrome, and we counsel. This come under pre-test counseling. And
so the counseling is being provided at your center.
yeah.
Counseling is being provided to the pregnant ladies regarding the different genetic disorders and how they can be prevented with the help of the prenatal screening. Like ma'am discussed about the Down syndrome, which is trisomy 21, and the Edward syndrome, which is trisomy 18. So it's a very important factor to educate the pregnant ladies which are coming to the center, in order to show them what are the necessary steps to be taken in order to find out the different genetic disorders. And so, like ma'am told us about the neural tube defects, do they also play a very important role, like as a cause of the mental retardation?
Yeah, in fact, Dr. Gurjeet will be sharing the informations we have. But what she was trying to show us, like this is called the pre-test counseling.
Okay.
Because before we plan to take a sample, we have to provide certain information to the mother. Basically, what are these tests, how much they cost, what are the likely result we have, what is low risk, what is high risk. So rather than having the individual session, we generally do it in the group setting. That's what Dr. Gurjeet was trying to demonstrate, that in the group setting we have the couple of mothers coming to the antenatal clinic, and before we take their sample, then we educate them.
And as you said about high risk and low risk, what is that? The high risk babies and the low risk babies. High risk,
high risk when we do a screening test, now it is a screening. So we can't make a diagnosis. So what we do is we have just done the alpha fetoprotein, the SCG beta biomarkers which we have done. We have a normal values for these biomarker during a pregnancy for specific period. Like we were talking about this test, they can be done twice during pregnancy. It is 11 to 13 weeks and between 15 to 20 weeks. From 11 to 13 weeks they have a specific value, normal value. Now if this value are altered from the normal value, then and we have a software, we use the software and we put those values, and then we come to know about the high risk group and a low risk group. If it is a low risk group, then the pregnancy, it is only low risk for chromosomal disorders and neural tube. We have to be very sure. We are just talking about, there are so many genetic disorders, we are just talking about chromosomal disorders and neural tube defect, and it is that low risk means that the risk of fetus having chromosomal and neural tube disorder is low. But if we talk about high risk means that we should be very clear, we are screening the fetus from mother's blood, so the pregnancy can also have an impact on the value. So we have to be very sure the fetus is affected or it is an impact of pregnancy. So high risk does not mean the fetus is affected. It commands further confirmatory test so that we are sure that the fetus is not affected.
And as like ma'am told us about the high risk and the low risk, so we have also discussed some causes in the postnatal stage. So like there is a thing known as Apgar score. So that is also used to find out the high risk and the low risk babies.
Yeah, that is more of a clinical indication we can have. This score clinically immediately after birth tells us that in case is there likelihood that the child might suffer some sort of trauma to the head. Basically we look at the clinical feature, look at the sort of the reflexes of the child, look at the color, respirator, pulse rate. So these parameters can indirectly give us an indication whether there is a likely risk to the child or not.
Over to you, ma'am.
Yeah, if it is a high risk, then now we have to be very sure that the fetus is not affected, because if fetus is affected, then these disorders are not treatable. So we have to be very sure, and this have to be done within 20 weeks of pregnancy, because till 20 weeks we have to make a diagnosis and the family have to take a decision. After that it is the legal
termination of the
pregnancy become difficult if they want to go for the termination of pregnancy. Now once it is a high risk, then till now we have evaluated the fetus from mother's blood.
Right.
So now the second step comes, we have to evaluate the fetus itself. We have to go for a special ultrasound, that is called level 2 ultrasound for soft markers like nasal bone, thickened nuchal fold, echogenic bowel. These are the like nasal bone. In case of Down syndrome, the nasal bone is absent or it is not a normal nasal bone. So these soft markers will give us the evaluation of the fetus. Now once we evaluate the fetus from head to toe completely for all the soft marker through ultrasonography, then we again calculate the risk. Now we again group the fetus into a low risk group or a high risk group. If it is low risk, then it is okay, low risk. But again if it is in a high risk group, then we have to go for invasive tests. Like we can't go for this invasive test, we can't go for all pregnant ladies. Suppose if there are 1,000 pregnant ladies, and if we think that we start from invasive test, then it will become very difficult to handle all these pregnant women, because invasive test also has its own impact of abortion and other things. So those coming in high risk, after special ultrasound, we go for diagnostic tests like chronic villus sampling, amniocentesis, cardiocentesis, and again through this now we can prepare a karyogram of a fetus. Now now this is the normal karyogram. If the karyogram of fetus is normal, then we know that the fetus is normal, and if the karyogram karyogram is affected, then through genetic counseling we tell them about the affected fetus.
And like the techniques that you have mentioned, if through these techniques we have found that yes, the fetus is affected, it's a high risk baby, then what's your advice on this?
When the pregnant lady is coming, so we have started, this all come under genetic counseling. Like we start pre-test counseling, we explain about the test, about what we are going to do, and if it is low risk or high risk, what we will do next and how we will proceed. So till the time all this evaluation is done, the pregnant lady had gone through quite lot sessions of pre-test, post-test counseling, and she is aware that if it is now if this karyogram will come, so that means the baby is normal or affected, and then we call the couple to our center, and again we counsel them, we tell them about the like consequence of pregnancy and about the disease again in detail, and they have to make their
So broadly, if I can add a word to whatever Dr. Gurjeet said, see, the genetic counseling, primarily what are we doing in the genetic counseling? We are trying to translate the findings of the lab
Exactly.
test in a language which is understandable by the couple.
Right.
So we are trying to inform them so that they are in a position to make up their mind, because we are not going to decide for them. What we are telling them that these are the results, this is what it means, these are the likely consequences, now you make up your mind. So that is broadly is the genetic counseling.
Okay. And then the decision is like left on to the couple whether they want to continue the pregnancy or
they
they
want to have
terminate.
because in developed countries they like to go for a Down's baby. They say we can take care of baby, so it is their choice if they want to have the baby with Down or any chromosomal abnormality. It is their choice. If they want to terminate, they can terminate. It is legal.
And
Within
in India
20
is
weeks.
also legal?
Legal within 20 weeks of pregnancy.
Within 20 weeks.
Yes.
And okay, like as we have discussed about genetic counseling, if the parents have decided to go for the pregnancy and after the newborn has been born, would you suggest like whether it should be under the newborn screening, and what are the techniques for the newborn screening? What is newborn screening like after the child is born?
See, prenatal and newborn screening are quite little different. Like in case of newborn screening, in prenatal screening we here in India are doing testing for chromosomal and neural tube defect, but there are certain defects which are called inborn error of metabolism.
Okay.
That is like what is newborn screening is when the child is with the mother, when the fetus is with the mother, the metabolites of the mother is supporting the metabolism of fetus, that is the normal growth and development of fetus is supported by the mother. But now as the fetus is born as a newborn and it survives on its own, and if there is a defect in its own metabolism, then it can lead to certain inborn error of metabolism, which are again a leading cause of mental retardation. So what is newborn is diagnosis of certain metabolic disorders during the asymptomatic phase before the manifestation of the disease take place. Through newborn screening, we within 24 to 72 hours of birth we can identify certain genetic disorders that can be treated or managed early in life.
And what are the details of the procedure as we are discussing about the newborn screening? What are the details of the procedure under the newborn screening?
See, with the advancement now, with the science has so much, technology has advanced. It is now there are protocols by using a single blood spot. We can evaluate lot number of disorders together, and timely intervention of these disorders will reduce automatically the morbidity and mortality of the associated disabilities. What happens is, with the same single blood spot, we can take care of so many disorders like congenital adrenal hyperplasia, congenital hypothyroidism, G6PD deficiency, sickle cell anemia, galactosemia, phenylketonuria, maple syrup urine disease, homocystinuria. Lot of these disorders are the leading cause of mental retardation if the metabolite is absent, and if it is not diagnosed timely, they are the major leading cause of mental retardation. So as now going back to your question, like you were saying about the newborn screening, like what is the simple method of going. What we do is we take a 2-3 drops of blood and we collect by heel prick on a special graded filter paper. This blood spot is collected on a special graded filter paper within 24 to 72 hours of birth, and it is dried, and through this blood spot we can test various metabolic disorders, and also this dried blood spot card can be stored, transported, and it is easy to handle. So this method of blood collection was first given by Dr. Robert Guthrie in 1960 and is called Guthrie's test. Like we can take example of, now this is like from a single blood spot we can do phenylketonuria, which is a common cause of mental retardation. Now what is phenylketonuria? Phenylketonuria, there is a enzyme phenylalanine hydroxylase. This enzyme phenylalanine comes from diet. Our diet consists of phenylalanine, and this phenylalanine is metabolized through the enzyme phenylalanine hydroxylase. If this enzyme is missing, then the phenylalanine will not hydrolyze and it will accumulate in the body tissues and mainly in the brain, and accumulation of phenylalanine can lead to mental retardation. But if during newborn screening, if we pick the phenylketonuria, this enzyme is missing, we can restrict the diet and we can give a diet free of phenylalanine and prevent mental retardation.
And ma'am, this phenylketonuria, it can be diagnosed only after the birth.
Yeah.
It can't be diagnosed before the birth.
No, yes, because the metabolism is supported by the mother. Until and unless the mother is phenylalanine deficient, then it is different. But if because metabolism of child starts only when the cord is cut.
And as we are discussing about this newborn screening, would you like to add on more on newborn screening?
Yeah, like this is congenital hypothyroidism. Also, if we can pick up congenital hypothyroidism early within after 24 hours of birth, and we can, which is also a leading cause of mental retardation, and it is 1 in 4,000. So it is common. It is very common. So by doing screening, we can pick up we can prevent mental retardation, which is through congenital hypothyroidism, and then it is adrenal hyperplasia, galactosemia. There are lot of disease which we can pick up in India itself, and we are doing all this. We are picking up all this disorder within 24 hours of birth and trying to prevent disability.
Do all the children have to undergo this newborn screening?
See, it is my baby look quite normal at birth. Are these tests still necessary? I will say yes. Now the question arises, why? Because the child may carry certain metabolic disorders not expressed during birth or few days after birth, but which may later on lead to serious mental and physical handicap. Early detection and management of these metabolic disorders can help a normal growth and development of a child.
So the answer is, having just a look at the child, we can't find out whether the child might have certain defects.
Right.
So it basically means yes, if possible, if feasible, all the newborns should go the screening programs in case we have the facilities.
And with all these tests that you have just mentioned, is it painful for the child to undergo all these tests, like the different set of tests we described? Is it painful?
I think if we see the agony and the pain the family and child goes once he's born with a disability, I think this small prick, which is equivalent to a mosquito bite, I don't think it is painful at all, right? And the sort of the perception of the child towards pain is negligible. So if there's a small heel prick, the child may not even have a feeling of a needle prick. So I'll say that it is not painful at all.
And what are the benefits of having this newborn screening? Like you said, every newborn should undergo this newborn screening test. So what are the benefits of this newborn screening test?
There are a lot of benefits. Like we can, first of all, we can prevent the disability by early detection. I think now it is very clear.
Right.
And intervention and treatment. And also we can improve the diagnostics and treatment. If we are diagnosing various tests, like we are doing phenylalanine, congenital adrenal hyperplasia, and we get, these are all screening tests. We have to be sure that these are screening tests, and then false positive rate, false negative rate, and by improving, like if we are in this system, by doing all these tests, we can improve our diagnosis and treatment. We can go for, we can advance toward better, we can decrease the false negative and false positive rate, and we can pick up certain disorders, and also we can establish the incidence of the disorder. In India till now we are not having any incidence of this disorder. And also one important thing is, if one, in one family a child is affected, now okay, it is affected, so we can't do much for that child, and but we can do the carrier status in the family, and through the prenatal testing we can prevent further coming of these disorders in those families.
So, we are in lieu of a discussion with genetic disorders and the prevention of the common genetic disorders with all the newborn screening tests and genetic counseling. We'll carry on with the discussion after a short break.
ऑटिज्म एक व्यापक विकासात्मक विकलांगता है जिसके लक्षण जीवन के प्रथम 3 वर्ष में ही दिखाई पड़ते हैं, जैसे असंगत खेल, असमान स्थूल एवं सूक्ष्म गामक क्रियाएं, शाब्दिक संकेतों पर अभिव्यक्ति न देना।
Where is the cup? देखो, open your eyes, open करो, open करके, open.
नियमित कार्यक्रम परिवर्तन का विरोध करना एवं अवलोकनीय शारीरिक उच्च स्तरीय या निम्न स्तरीय क्रियाकलाप। UNCRPD 2007 सेक्शन 1 ऑफ आर्टिकल 4 निशक्तता के क्षेत्र में कार्यरत प्रोफेशनल के प्रशिक्षण पर महत्व देता है। ऑटिज्म के क्षेत्र में सरकारी एवं गैर सरकारी संस्थाएं कार्यरत हैं जो भारतीय पुनर्वास परिषद द्वारा पंजीकृत हैं। सोसाइटी फॉर एडवांस स्टडी इन रिहैबिलिटेशन एक ऐसी ही गैर सरकारी संस्था है। कनिष्क 13 साल का एक ऑटिस्टिक बच्चा है जो इसी संस्था से प्रशिक्षण प्राप्त कर रहा है। असंगत क्रियाएं, कार्यकलापों में निरस्ता, असमान स्थूल एवं सूक्ष्म गामक क्रियाएं जैसे बॉडी रॉकिंग और फिंगर रिगलिंग उसमें देखी जा सकती है। उसे मैचिंग और पेस्टिंग, पॉइंटिंग जैसी क्रियाएं सिखाई जाती हैं।
वेरी गुड। ग्लास, वेयर इज द ग्लास? ग्लास, वेरी गुड। कप को टच करो जल्दी से, कप को। वेयर इज द कप? वेरी गुड। कप में क्या करता है कनिष्क? टी पीता है। चलो ग्लास, वेयर इज द ग्लास? वेरी गुड। चलो बाउल की तरह, बाउल जल्दी से टच करो बाउल को। वेरी गुड। बाउल में क्या करता है कनिष्क?
तथा साथ ही साथ रोजमर्रा की आवश्यकताएं जैसे खाना, पीना, कपड़े पहनना, और व्यायाम संबंधी प्रशिक्षण दिया जाता है। ऑटिस्टिक बच्चों को भिन्न भिन्न प्रकार की कार्यविधियां उनके स्तर के अनुसार सिखाई जाती हैं, जैसे कुछ बच्चों के लिए कलरिंग विद इन वन एरिया, मैचिंग एंड आइडेंटिफिकेशन, फाइन मोटर स्किल्स, आई हैंड कोऑर्डिनेशन, कंसेप्ट ऑफ वेजिटेबल्स, फ्रूट्स, बॉडी पार्ट्स, कलर्स पर जोर दिया जाता है तथा कुछ को प्रश्न पढ़ के उत्तर देने में और रोजमर्रा की आवश्यकताओं को पूरा करने में सक्षम बनाया जाता है। इसके अलावा राइम्स, डांसिंग, सिंगिंग द्वारा लेजर एंड रिक्रिएशनल एक्टिविटीज में भाग लेने के लिए प्रोत्साहित किया जाता है। इन सभी कार्यकलापों एवं प्रशिक्षण का एकमात्र उद्देश्य उन्हें स्वनिर्भर बनाना है, ताकि ये डगमगाते पांव सक्षम बन जीवन के एक एक पायदान पर दृढ़ता से आगे बढ़ें और अपनी मंजिल को पा लें। एक तारा टिमटिमाता, उसने आकाश को छू लिया। एक लौ जली कहीं, उसने अंधकार को मिटा दिया।
हम होंगे कामयाब, हम होंगे कामयाब, हम होंगे कामयाब एक दिन। ओ मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन। We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe that we shall overcome someday. We shall overcome someday. We shall overcome someday.
Welcome back. ब्रेक पे जाने से पहले we have discussed about different genetic disorders and what are the ways in which we can prevent these genetic disorders. We discussed about prenatal screening, we discussed about what are high risk babies, what are low risk babies. Then we discussed about the genetic counseling, the newborn screening. What are the methods in newborn screening involved, and do every baby have to undergo these newborn screening tests? We were discussing about the benefits of the newborn screening test. So over to you, ma'am. Would you like to continue with that?
Yeah. So it is like I would like to tell here that more than testing, it is the lifelong management of disorders. Once the disorder is picked, then we can prevent disability, but the child have to be on treatment throughout life. So I would like to say that the infants affected with disorders detected by usually requires lifelong management. So before we go for such type of testing facilities, we should know that the affected child needs treatment and care. So this treatment and care should be accessible, it should be continuous, it should be comprehensive, coordinated, compassionate and family oriented. That means it should be easily accepted, it should be acceptable, it should be continuous treatment should be there, and it should be cheap also, and also the family is oriented towards such type of treatment.
It's a like ma'am told, it's a lifelong management thing. So as you were discussing about the different wards and different divisions at your setting, like the special education wing, the medical wing, in every wing, do you also have different parent support services? Like as ma'am said, it's a lifelong management thing. So do you also have support services available for the parents?
We do have the parents coming together. In Chandigarh, at least we do have the 3 important self-help groups which have come up, which means that the parents got together and with the help of the institution they are working. But we don't have the specific self-help groups which are coming up, like the parents of the children who have phenylketonuria, right? So those things I think should come up. If we have that type of group, definitely they provide support to each other. It is a great help, and they can work with the professionals in terms of creating extra facilities,
Exactly.
right? And they'll be a sort of a backbone. Those things need to be come up.
Okay. And ma'am, like we have discussed about different genetic disorders. So like at your setting, what are the most common genetic disorders which you have seen, like at your setting?
See, our center at Government Medical College is recently we started in 2006. We are not very old, just 2006 we
Okay.
have started, and
We may be
till-
old, but our center is not old.
and we started with triple test facilities. Triple test include for chromosomal abnormalities and neural tube defect. So till date we have screened around 5,000 pregnant ladies, and through out of these 5,000 pregnant ladies we have got 288 as high risk pregnant ladies, and out of these 288 they all have gone for ultrasound level and if needed diagnostic test, and we found that 241 were normal. Out of these 288, 241 were normal.
Okay.
But you can see 12 were like the babies fetuses were with congenital malformation. 5 fetuses we picked up with Down syndrome, and we have prevented like Down syndrome, and then 5 with intrauterine fetal diminishes, 4 with spontaneous miscarriages.
So ma'am, I think with all these tests, with all these procedures, I think most of the parents must have this query in their mind, like how expensive these tests are.
See, these tests are not expensive as such. Like in government setup, once the infrastructure is there, then if we talk about it cost us just 300 to 400 rupees.
Even for the chromosomal test. That
Chromosomal and but we are not having centers in India in government
Right.
setup, and private people they are having these facilities and they are charging like 2,000, 2,300, 1,600. So they are charging a lot. But if these facilities come up in government setup and we have a infrastructure, then the charges are just 300 to 400 per test.
And these tests are only available at the genetic centers only, not at other hospitals, only at the genetic centers.
No, they
Selected
are.
okay.
No, they are available. Like in AIMS, this test in Delhi at AIMS, these tests are being done at anatomy department and genetic center. So they are available at hospital as such, and we are not having genetic center or.
But yeah,
Exactly.
but the point you had is quite important. They are not routine tests. Like you can't just walk up to a clinic, a laboratory where you get your hemogram done. So you can't go and ask for the genetics test.
Yeah.
So
Right.
you need to have a complete infrastructure, right?
Yeah.
A center.
Exactly.
Yeah.
And these genetic disorders, are all genetic disorders treatable?
No, we should be very clear that genetic disorders are not treatable.
Okay.
They can be prevented through prenatal screening program, or they can be if the baby is born, then it is through newborn screening program we can manage it. And if the child is affected and there is no management for such type of disorders, then through genetic counseling we can prevent further like through prenatal testing in the subsequent pregnancies we can prevent such type of disorders.
Dr. Gurjeet also has our experience of the newborn screening
Yeah.
program in Chandigarh. So would you like to share that also?
Yeah, in newborn screening we started in May 2007, and we started for G6PD deficiency, congenital adrenal hyperplasia, congenital hypothyroidism, because we wanted once if it is screen positive, then we should have management for those particular disorders. So we just started with these 3 disorders, and we found that we screened around till date we have screened around 8,000 newborns, and out of these 8,000, 81 were grouped into low risk and 244 were grouped into a high risk or a borderline for this G6PD deficiency, adrenal hyperplasia, hypothyroidism. And from this 244, 106 were grouped in G6PD deficiency, and 26 for adrenal hyperplasia, and 29 for thyroid stimulating hormone. but now again I will like to emphasize that these are screening tests. These are not confirmatory tests. So once the newborn is screened positive for these tests, we have to go for further confirmatory tests to be very sure that these are existing. Now see, in case of 106 G6PD deficient, only 65 when on confirmatory test, only 65 came out to be G6PD deficient, and adrenal hyperplasia, only one was picked as adrenal hyperplasia, and hypothyroidism, only 2 were picked. They are not like so common, but
Right.
they are existing, and we can manage these disorders if they are picked up early during newborn period.
And now, what is this G6PD deficiency?
See, G6PD deficiency is on RBC. RBC is stable with this enzyme G6PD. It is if this enzyme is not there, then what happens? The RBCs can lyse. They are destroyed, and then once the RBC is destroyed, the hemoglobin is released, and it becomes fatal.
Okay. And where are the facilities for these genetic screening in India?
Before we come to that, some of our viewers might be wondering that after screening about 8,000, more than 8,000 newborns, we picked up just one case of congenital adrenal hyperplasia and just 2 cases of congenital hypothyroidism and 65 that. But let me add a point here,
Yeah.
that if we look at the cost of looking after one person with disability throughout life, this cost is fractionable whatever we have put it. So even if we are able to prevent disability in a child, in one child, I think this is worth trying it.
Exactly.
Yeah.
And as ma'am said, like you have screened so much, like 8,000 pregnant
8,000.
ladies, and it's not possible that always the screening test, they are confirmatory.
Yeah.
So that's why there is a like remarkable
There is a
significance
false
in
positivity and false negativity is there.
Yeah.
Okay.
You had a
Yeah. And where are the facilities for these genetic screening?
See, in north we are the only one, and in Delhi, in AIMS, we are having this facility. Gangaram has this facility,
Okay.
and Chennai, all cosmopolitan cities like Chennai, Hyderabad, Bangalore, Bombay, they are having these facilities. And in north, after Delhi, we are the only one in Punjab, Haryana, Himachal Pradesh. We are the only one who have started this in 2006.
Plus, the most important part of the genetic center we have in Chandigarh is that it is the only center of its kind working on the disability. So the priority of the genetic center is basically to pick up the disorders which lead to disability. I don't think we have any other genetic center which is exclusively working in the area of disability.
Exactly. And
Say,
what
newborn
we-
screening,
yeah.
we are the first in India to start. There are the tests are available in Gangaram AIM, but they are just picking up in those who are like high risk group. They are not screening. We are screening all the newborns born at our hospital, whether it is Sunday, gusted holiday. We are going and collecting sample for these tests.
Okay. And like we can say, parents, they are very in a problematic situation, because genetic tests are available at one center, then they have to rush to the other center to have the IQ testing, then they have to rush to the other center for the special education thing, for physiotherapy, for occupational therapy, for different other services. But your center, I can say everything, like it's just
yeah.
situated at one place. You have to like have the genetic testing, and the further procedure
Yeah,
will
all
be
the
taken up.
facilities
Yeah.
are under one umbrella.
Under one
Yeah.
roof. Yeah.
Yeah, and in fact that was the only motive we had in mind, rather than sort of asking parents to go around, spend a lot of time and money in traveling and requesting the facility, standing in
Exactly.
long queues. So we have tried to create all the facilities under one roof.
And as you said, like, and we have seen also that newborn screening and this prenatal screening, all these tests, they play a very crucial, they are very crucial in terms of detecting the mental retardation and in terms of prevention. But why such centers are limited? What's the problem? Where are the lacunae? Where the gaps are there? Why such centers are limited?
See, yeah, I would like to
Yeah.
show one. For having a good center, we need first a infrastructure. Then we need a manpower, and we need planning. Planning is very important, and then it is coordination between all concerned department. That means the concerned department means the pediatrician, the radiologist, the gynecologist, the genetic center, and the manpower working for the genetic center. And then it is the equal participation of everybody. And then it is the financial support, which is very important from the administration, because developing a center under one roof to prevent disability need a lot of finance, and these financial supports from the administration is very important to understand like what we are going to establish and how we are going to prevent disability, and to release the grant is very important. And then the coordination between all of the person concerned, all the department, these are programs, not just a facility. These are, like we say, it is a prenatal screening program include all this manpower, planning, coordination, equal participation, finances, and mainly it is the awareness in the public that they have to go and get this test done. That is also very important. In India we are not having awareness, like what is prenatal testing, what is newborn testing. We are not having awareness. When we started, we were like surprised that there is no awareness. Then we started first with awareness program, and then we started with testing all this.
And according to me, like prevention, as we have discussed, prevention of various genetic disorders and prevention of mental retardation, we can say it's not just about preventing. Okay, it's very important for the genetic disorders and for all the causes, but after you have discovered, yes, the child is having mental retardation and he needs certain interventions and treatment, in terms of prevention, I can say psychosocial abuse, which is a very important factor, like in our society, that's also to be prevented, which can also be considered under the aspect of prevention. Because we are discussing about prevention of genetic disorders, about different various causes in prenatal, natal and postnatal period. But what about after the child has developed that disability and he has to be like looked down by the society? So psychosocial abuse, I think that's also an important part of prevention which can be taken care
So
of.
yeah, for this government have to play a very active
Exactly.
role. Like in the developed countries, the government is taking care of there are homes for there are special schools for there, and till they are alive, it is the under the government, the finances are taken care by the government, the responsibility is of the government.
But I think now the things are changing. Let me make it very clear that we are now shifting from the charity base to a right based approach.
Exactly.
Right, there was a time when we said that yes, we must do something for these person with mental retardation. Now we have changed. Now it is a right of a family, of a person, to seek benefits, to seek services. Right, so with the Person with Disability Act, with the United Nations CPRPD, we are a part of it. That so now I am sure that things are going to improve. With the Person of Disability Act, now there cannot be any discrimination toward the family and the child.
Right.
There is a Chief Commissioner of Disability who will look into the complaint if somebody says that there is a discrimination of my child. Right. So we are talking of the barrier-free environment now.
Exactly.
Right. So things might change in the near future.
And like in your center, as you described, that you also have vocational training centers which takes care of the employment and the placement. So what type of vocations you are like trying to teach these children having mental retardation?
Yeah, in our earlier program we shared a lot of information about the vocational centers we have, where we are working on the paper recycling unit, like the used papers is converted into the handmade sheets. And a lot of things are being made out of that. We have a carpentry section, we have masala grinding and packing sections, and I think Dr. Gurjeet has certain clips. Before I add up, you want to show some of the things we have? Yeah, please.
Like this is like of the session we go for pre-test counseling and post-test counseling.
In case the mother is high risk, then there is an individual counseling.
Yeah.
Yes, this slide is showing about the counseling, and then I would like to show other.
Yeah, the individual counseling, like the mothers which are identified for the high risk fetuses or high risk babies, they go for the individual
Yeah, it's
counseling.
quite scaring if you tell a mother
Exactly.
that you have a high risk. You look at that mother, she is under shock.
Exactly.
So you can't leave her there. You have
Exactly.
to take her out of that. So it needs lot of explanations, lot of support, lot of counseling, and lot of guidance that yes, what she should do now. So doing a test is simple, but handling that test and working with the mother is quite a difficult and quite a time consuming challenging
yeah.
task.
Like this is the slide showing about our how this tests are being performed at genetic center, and we are using this software to calculate the risk, and like we are preparing the report, and now this report is showing that when we put this biomarkers value, we get the risk, whether it is a low risk or a high risk.
Baby.
So,
So,
whatever
yeah.
whatever test we have done, we can generate a report. So the report is in front of the mother, and she can carry this report, discuss with another professional, go to the clinician, the treating doctor, so now this report is generated, and there is a computer generated report.
Okay.
And
Can we
this
have the
is,
look at the video? Yeah.
Yeah, this is how karyotyping is being done at our department. Like we are preparing the slide here and then viewing under the microscope, and then we have a imaging system. This slide is imaged on the computer like this. Here we get a karyogram, we prepare a karyogram, and by this karyogram we then are able to detect whether it is a normal karyogram or abnormal. And this is a FISH technique. What is FISH? Is fluorescence in suit hybridization technique.
Okay.
This otherwise karyotyping take around 4 to 6 weeks, and by this FISH technique within 48 hours we are able to give a report, generate a report whether the karyogram is normal or it is affected. So this is a fast technique.
Okay.
And
Would you like to add on more? Like there are more videos?
Yeah, maybe.
So we have seen a video on individual counseling
this
on the
is-
karyotype. Yeah.
This is a polymerase chain reaction. By this, if there is some genetic defect like fragile legs, muscular dystrophy,
Okay.
we can, using this machine, we are able to detect like whether these defects are there or not, and also the carrier status, and then we can help the families we counsel them, and then we help the families so that to make for the next pregnancy we plan their they can plan their pregnancy, and we can have pre-test testing also whether the baby is affected or not.
And as we have discussed about the biological causes, which are genetic and prenatal, natal and postnatal causes, what do you think environment, what is the importance of the environmental factors which can lead to mental retardation?
I think environmental factors are very important. Particularly, they are more important when the child is more vulnerable. Vulnerable would mean that he has certain predisposition, and if he is exposed to a hostile type of environment where the child does not get the adequate diet, he does not get adequate emotional support, there's a social deprivations, there are more chances that this child will have the learning problems, and he might have the disability appearing, or it might worsen. So environmental is as important as the biological or the genetic factors. Very, very important.
So in today's session, we discussed about the prevention of the person with mental retardation. We discussed that mental retardation, it occurs in about 1% of the total population, and it is more common in males as compared to females. We discussed, or we attributed two different causes for two different types of causes for the mental retardation, which can be biological and environmental. The biological can again be divided into the genetic factors and the prenatal, natal and the postnatal factors. If we talk about the prenatal factors, then we can attribute it to maternal age, nutritional status, maternal stress, drug abuse. These are preconceptional basically. And if we talk about the natal causes, then we can say the prematurity or the post-maturity, then prolonged labor or forceps delivery or any kind of birth trauma. And if we talk about the postnatal causes, then these are delayed birth cry, trauma, seizures, lead poisoning, jaundice or diarrhea. These can be attributed to the postnatal causes. Now we have seen that genetic causes account for about 21% cause for the mental retardation, and there are different kinds of genetic disorders such as Down syndrome, Edwards syndrome, Klinefelter syndrome, Turner syndrome, and basically these genetic disorders, they arise due to the change in the number of the chromosomes or the structure of the chromosomes, or there is an alteration in the gene structure. And in prenatal stage, the most common cause of the mental retardation are abortions, and in the natal, these are the prolonged labor, and the postnatal, these are the delayed birth cries. Now, for the prevention of the genetic disorders, these are various techniques which we have discussed. We discussed about the prenatal screening, we discussed about newborn screening, various tests under these screening, and we discussed about genetic counseling, and we have seen also many videos and how the prevention is an important aspect in the early detection, intervention and the treatment of the mental retardation. So that's all for today's session. But before that, I would like to thank both of you for coming over here and discussing with us. Thank you so much. And thank you viewers for maintaining with us. Thank you so much.